Do you routinely offer early ortho treatment in your practice? Or do you, like some, consider it a marketing tool with little and no benefit to the patients? Today's topic, early treatment, yay or nay? Stay tuned. Our Golden Age of Orthodontics podcast sponsors make it possible for us to bring you new episodes. Cale Owen is revolutionizing orthodontics by turning the chaos of conventional braces into custom control. Their custom digital solution helps you achieve consistent results while saving on average over 7 appointments per patient. It's custom done right, so you can focus on delivering amazing smiles. Find out how Cale Owen can modernize your practice. Book a demo today and get $250 off when you mention People in Practice to your representative. Created by an orthodontist, Grin is redefining remote monitoring with a cost-effective solution that boosts practice efficiency while delivering personalized care for each patient. Grin provides you with dedicated assistance, enabling you to focus on providing exceptional care, all while saving valuable time for you and your patients. New customers can save up to 35% on their starter package. Transform your practice. Better care begins with Grin. To find out more about our podcast sponsors, visit pplpractice.com/partners.
The future of orthodontics is evolving and changing every day. But although the way to achieve practice growth has changed, there's never been a better time to be an orthodontist. Let's get into the minds of industry leaders, forward-thinking orthodontists, and technology insiders to learn how they see the future of the orthodontic specialty. How will digital orthodontics, artificial intelligence, clear aligner therapy, remote monitoring, in-house printing, and other innovations change the way you practice? Join your hosts Dr. Leon Klempner and Amy Epstein each month as they bring you insights, tips, and guest interviews focused on helping you capitalize on the opportunities for practice growth. And now, welcome to the Golden Age of Orthodontics with the co-founders of People in Practice, Dr. Leon Klempner and Amy Epstein.
Welcome to the Golden Age of Orthodontics. I'm Leon Klempner. If you don't know me, I am a retired board-certified orthodontist. I'm also the director of ortho at Mount Sinai here in New York, and part-time faculty at both Harvard and Montefiore. In addition, I am the proud CEO of the best marketing company in the world, People in Practice. And as usual, I'm joined by my partner, by my daughter, and my co-host, Amy Epstein. How you doing, Amy?
Doing well. Glad to be here today, and especially with the guest that we have for you. Yes, so by way of background, I'm Amy Epstein. I am the Chief Operating Officer of the best marketing firm for orthodontists around.
And pediatric dentists.
Oh, by the way, we're an award-winning podcast now, by the way.
Yes.
Pediatric dentists. We're an award-winning podcast now. So we're very proud to be continuing to do this podcast and providing high-quality information and guests for you. Today, I'll talk a little bit about our guest, Dr. Daniel Grob, in a second. But we had like a little chat before we are recording our podcast, just get to know each other, talk about topics, talk about what might be interesting for our listeners. And it was very inspiring to me because I have a 7-year-old, as you know, Dad, because she's your granddaughter. And we're going to talk about early ortho today. And, since that conversation, not only did I learn a lot, which is, frankly, we've had People in Practice for, 15 years? And my clients are all orthodontists. And my father, as you know, Dad, is an orthodontist. And I basically grew up in an orthodontic practice. And yet I still learned a lot in that discussion that we had with Dan. It was inspiring to me. And I'm bringing my daughter in for a consult because, I think that she could benefit from being seen and at least get some more information about whether or not it's the right time for her. So you haven't seen her in a little bit, Dad, but she's getting real crowded down there.
I know. And this is a hot topic in ortho. This has been bounced around for, I've been around a long time. And from the beginning, this has been, volleyed back and forth in terms of value, no value, do it, don't do it. And people they're pretty set in their ways, I found. And I personally did a lot of early treatment in my practice. I'm a big fan. But I know that, in the residency programs that I teach, they get very little. I give a lecture on early treatment. We talk about it, but the reality is that in training, there is very little opportunity for early treatment. We have the residents for 2 or 3 years, and it's a lot to just teach them how to treat a case with extraction. So
right. Well, that's why we're very lucky today that we're joined by really a pioneer in pediatric focused orthodontics, Dr. Daniel Grob. He is a board certified orthodontist with over 4 decades of experience, much like you, Dad. But Dan is still in practice. He's treated tens of thousands of patients, and he's built his career around delivering thoughtful, comprehensive care with a strong emphasis on early intervention. Dan actually, he has a dual specialty in both prosthodontics and orthodontics. And he spent his career not only transforming little smiles, but also big smiles, and educating, like you do, Dad, the next generation of clinicians. He's also seen it all, from founding a multi-location practice to building a thriving dual specialty pedo-ortho model in partnership with a pediatric dentist from the ground up. And so speaking of education, founded a Facebook group called the Pediatric Orthodontists. And for those listening today, if you're interested in early ortho, you should go check out the Pediatric Orthodontist on Facebook and ask to be included in the group. And if you look at your, couple years back of Ortho Town magazine, we'll see his name because he was the editorial director for some number of years. And his monthly columns shaped conversations about phase 1 care for a good number of years, right, Daniel? So welcome. Thank you so much for being here today. I appreciate your time so much.
Well, thank you for the nice introduction. And I'm very, very happy to be here to spread the word that I'm working on perfecting and making a good experience that of early orthodontic care. I certainly didn't start out in practice doing this. As you mentioned, I started in the field of prosthodontics, and back in the 80s and 90s, it was thought that would be a really great combination, prosthodontics and orthodontics, because in the 80s and 90s, adult orthodontics was just coming into play. And what a better dual specialty than prosthodontics and orthodontics, so that you could treat all these adults. And back then, surgical orthodontics was coming into play. So we had a thriving practice in Wisconsin dealing with adult orthodontics, oftentimes involving jaw surgery. That kind of dried up when insurance benefits were cut back a little bit. So I just migrated to Tucson and had a conventional multiple office orthodontic practice, where about 15% of my practice was spent on early treatment. I can still remember visiting general dental offices saying, I'm an orthodontist, I'm in the neighborhood, don't worry, I don't try to lock up your patients early and waste their money on early treatment.
So Dan, let me interrupt you just for a second.
Sure.
Because I'm going to give you the pushback argument here. And as someone teaches, in residency programs, we want to look at evidence and evidence-based and make decisions. But, when I do a literature search, and I look at the studies that were done, all of the studies, other than, let's say, instances where they have a large overjet and there might be some trauma, or maybe if there's a, deviation in terms of a crossbite, those are typically the 2 areas that everybody agrees on. And then, if you're looking at the articles that are written and the studies that I found, they all say that you can get the same result. This is the big argument, is that you can get the same result treating in 1 phase later on rather than treating in 2 phases, whereas 2 phases cost more money and takes longer. So let me give you a chance to answer that question. So why? Why would you choose early treatment if, according to whatever's been published, you can get a similar result by doing it in one phase?
I think a lot of those, in some of the writings that I did for OrthoTown, I researched some of those articles also. And many of them came out of University Pacific. I think Dugoni had something. And I think I think the articles that you and I both are familiar with are comparing early treatment with the same end goal. And I think the end goal was taking someone from class 2 to class 1, or making the teeth straight. And I personally think that the evolution of early treatment has led to a different end goal, where we're looking more at the face balance as opposed to the dentition. And personally, I think that cone beam x-rays have changed the way I know I look at a patient. And it takes a while because, I've only been a cone beam owner for less than 10 years. But until you've had the opportunity to view patients as a volume rather than a linear dentition, you're using kind of a false premise for the end goal. And when they say, well, you can get the same result treating late or early, well, the results they're looking for sometimes involve serial extraction, sometimes involve taking out a couple of teeth. And I don't want to say that I get up every morning and promise the world that I'm not going to remove permanent teeth. But I think with the advent of the cone beam x-ray machine, you start looking at the transverse dimension much more than you did in the past. And I know Ricketts talked about frontal x-rays and things, and I still credit him as being a pioneer, and I think, Leon, you'll respect him also. Mm-hmm. I think he really got us looking at in the transverse dimension. So my end goal now is to develop width to the face and to the smile. And I look at patients and I decide if I need early treatment to create some width for the future, that's when I get involved. If I don't need early treatment to create width for the future, I'll pass on early treatment and perhaps take care of the patient in one extended phase, or in the instance of someone that, like a 13 or 14-year-old that comes in with no history of habits, no transverse dimension width problem, I'll wait for all the teeth to come in so that I can get the patient done in a year and a half or whatever. There's no doubt about it that early treatment does add some time and some cost. But the vast majority of the patients that I get involved with in early treatment, the parents are very happy. And they bring their second child and their third child, and they know that this is the way we work. And I think there's also the factor of society and psychosocial benefits. And a lot of the parents in my neck of the woods, in my neighborhood, want their kids to look as best as possible for their age group. And it's not that we're putting braces on and dragging it out for 5 and 6 years. It's my goal, and I think it was mentioned in the last editorial that I wrote for OrthoTown, was I'm constantly working on trying to perfect phase 1 in 15 months or less, and phase 2 in 18 months or less. And if you add that up, you might have 2.5, 3 years of treatment, which isn't extraordinary. I mean, I know that there are some patients that can be treated in 9 months or 15, but I think it's worthwhile, and I think it's beneficial. And I would
imagine, Dan, that there are others like me with little kids and concerns. So how are you finding the sort of market in terms of the demand for early ortho? Do you see people like me coming in with I don't like the way this looks, or I'm having trouble with keeping the lower teeth clean? Is that a driving force in your focus?
Well, most of the parents, and the beauty of orthodontics is, the parents can look at their kids' smile and see if there's room or not. So they see that. I practice next to a pediatric dentist who's very attuned to, they have a standard protocol of bite wing x-rays, Panorex at a certain time. And all day long, he's explaining to parents that there's not room for the teeth. And in the past, I think we were setting parents up for taking out first baby teeth and then perhaps some permanent teeth. I can honestly say that in the 6 or 7 years that I've been in practice with the pediatric dentist, I have signed a letter to take out 4 permanent teeth in less than a dozen times. And we've had hundreds of patients treated. And I feel pretty comfortable that it doesn't necessarily protrude the teeth. I remember when I first moved to the Phoenix area from Tucson, I took out a pediatric dentist to lunch and I said, so what bothers you the most about the orthodontic results? What can I make sure that I'm doing to keep you happy? She says, I don't want to see teeth protruding when you're done. And I think in the world of cosmetic orthodontics, we're very aware of the fact that the upper incisor should be upright to the floor and that provides the best bounce of light off of the front of the teeth. So we work very hard to develop width, and we work very hard to make sure that the central incisors are standing upright and straight when we're done. And if there's flaring, that's when teeth have to be removed.
Yeah. And I know, I've heard you speak before in conversations I've had with you, because we're aligned in so many different ways, but you introduced a few things that I was not aware of, which was the significance of oral habits in terms of the developing dentition. Could you talk a little bit about that?
Well, in about 2 months, an in-office research project is going to be released in Orthotown, where we took 3 months of all new patients, all recall patients, and all patients in between phase 1 and phase 2. And we asked the parents and the patients to self-report. So from the standpoint of a true scientific paper, it probably won't pass muster. But we found that close to a half of all the patients that present for early treatment or are involved in early treatment have some type of habit. Edward Engel in 1907 in his textbook stated that of all the things that mess up people's teeth, mouth breathing's the worst. Well, we found that nail biting is even more prevalent in our practice than mouth breathing. And the total tabulation of the results will be available in Orthotown. But suffice it to say that almost half the patients that come in for early treatment have some type of a nasty habit, whether it be mouth breathing, nail biting, thumb sucking, it goes on and on. And I mentioned thumb sucking because when you talk about oral habits, a lot of patients think, oh yeah, thumb suckers. That was actually at the bottom of the list. In other words, the overt thumb sucker really isn't the problem. The bigger problems are the hidden habits, the mouth breathing, where the mouth is hanging open, causing the buccinator muscle to collapse, the tongue sits low, or the nail biting. And nail biting habits cause all kinds of muscle imbalance. And part of the article that I'm working on this weekend and need to get into the producers by the middle of July shows adults that come in with crazy dentitions. And when you probe them, you find that the same light, gentle pressure that we use to straighten teeth has been used to cause their malocclusion. So I almost never let an early patient leave the office after an exam without determining why they need early treatment. And almost always there's some type of an oral habit.
Yeah, that makes sense. So people in practice, something that we do at the start of any engagement with an orthodontist to try to help them market their practice is to understand what makes them different in their community, what their strong suit is, something that patients value, that they can do consistently, and that's relevant in the marketplace, and also that their competitors are not doing, to help find that almost like single source of truth, North Star message that we build all of our marketing around to present to the community, so that people like me who are looking to bring their kid somewhere. I have a treatment age, a 10-year-old, and I have a 7-year-old, but no matter what I'm looking for, I know that this practice is good at this and this practice is good at this. Seems to me that you have a very strong handle on what your differentiated positioning is in your market. First of all, I mean, it's a different angle, certainly, than most orthodontists talk about. How do you talk about the practice? I guess there are two parts to the question. One is a little bit about how do you educate parents about phase one, and the other is like, how do you use this differentiation to attract more of the patients that you want to see?
Well, we're very fortunate, for one, to have a pediatric dentist that we've worked with and a pediatric dental office staff that we've educated to explain to them the transverse dimension and habits. When the pediatric dentist staff goes out to the grade schools and talks about brushing teeth and fluoride and don't eat candy, we follow up and we step in and work with educating the parents and the kids about oral habits. Just a very simple message. Thumb sucking, mouth breathing, things like that. Our marketing collateral has been designed to highlight that, where we talk about the stages of eruption. My first article with Orthoton was on treatment by 12s. In other words, early treatment is taking care of the first 12 permanent teeth that erupt. Comprehensive treatment is taking care of the next 12 permanent teeth that erupt, the buccal segments. And then after the 12-year molars erupt, you're basically into the adult dentition. I haven't really expanded that to include a whole lot of primary only, although I do have some pediatric dentists now that are reaching out to me, and we're meeting and talking about how we can do that effectively and scientifically, like you said, Leon, to make sure that we're using evidence-based things, because I don't want to create a firestorm of early treatment and be known as someone that's wasting parents and kids' times. But I think there are situations where we can start treating the 6-year-olds and just getting a few teeth and start to expand. Like I said, I've never been an early adopter on pretty much anything in orthodontics. And this realization of the benefit of early treatment is, like I said, is kind of an epiphany that came to me 5 or 6 years ago. And I just said, the best thing is it makes the practice of orthodontics easier. Not only are you delivering an attractive looking kid with all of their teeth, but every day in my office is just so much simpler than the transverse deficient patient that shows up at 14 or 15, where the parent says, we've been waiting for all the teeth to come in. And you know the look of this patient, Leon. It's a narrow upper jaw, flared incisors, class 2, and you're left with, okay, are we going to do this surgically, or are we going to do this or that? And we just don't have that. And when we have a 13 to 15-year-old with all of their teeth and that protrusion and the narrowness, it's almost always a patient that just showed up at the pediatric dentist for the first time, or someone that was referred to us by someone that said, oh, they do a great job. And then I'm left to explain to them that, well, we have to start with width. So, you're a little old for the conventional expander, so we might have to do a SARPI or like a surgically assisted type expansion. And then we're left with the protrusion. I feel pretty comfortable using Herbst appliances when people reach double digits in age and things. But once you start getting into the teenage years, you got to start making some decisions as how you're going to deal with that. So my practice, as a rule of thumb, does not have to deal with that occurrence too often, just because we're blessed with having the referrals at age 6 to 9 for the early treatment. And there are plenty of young kids that I pass on. It's when they have enough maxillary width and I feel that I can get it done in one phase.
So you have the benefit of partnering up with a pediatric dentist who it sounds like is doing the education and making the referral and saying, this is, your child has a couple of things that we are going to make it easier later on, and even perhaps make it better for them from the self-esteem point of view in their younger years, even before all the permanent teeth erupt. We work with a lot of practices that, are not pedo-ortho practices. And so, just as a thought for those listening about how to solve for, this is the parent talking. Well, I waited until all their permanent teeth came in, and now I'm in front of you, right? And so the problem to solve is, if you don't have that education coming from a pediatric dentist, how do you insert yourself in there? And there are plenty of AAO tools and resources with 7 and up type stuff. But our perspective is that this is a job for educational advertising, where if you want to have those kids come early, like Dan's saying, and be able to make space younger to make it easier later, then you have to reach those parents when their kids are 7 and 8 or younger, and reach them with things that they can understand and identify about their children, and give them the call to action that if these things are going on, then perhaps it's time to come in and see our practice. We specialize in early ortho, and we're wonderful with kids, and we make it life easier when all the permanent teeth erupt, and come in to learn more, or click to our website to learn, see this article and read more. So from my perspective, I can see, and I can imagine many of our listeners are thinking, I'd like to be able to do more of this, but how do I solve this issue?
Leanne, I'm sure you know, and Amy, from your marketing experience, that practicing is almost constant marketing. And I know we are very big and focused in our practice on intraoral photography and creating presentations. So, I don't visit the general dentists so much anymore, because I have access to the pediatric dentist, and then sometimes those patients refer, and then we'll get a referral with a different general dentist, and then I will go out and visit, like a lunch and learn, the other general dentist with a small slideshow, a couple of tools. A cotton roll is 36 millimeters wide, and a cotton roll held up on the roof of the mouth should fit between the upper molars, and if it doesn't, that patient is maxillary deficient. Now, if it's only a couple of millimeters, that can be picked up later. If it's significant, that's something to look for. So I show the general dentist and the staff that, you've got a box of disposable rulers that you can put on your exam tray, and take a tweezers and hold it up to the molars and see how wide the molars are. And that's research from James McNamara, who's legendary. I mean, I grew up with McNamara and the Frankel appliance, and I'm heading into my sunset years with McNamara and his transitional dentition treatment. So I think he's probably been the biggest influence in my practice is McNamara. But we've got a couple of lunch and learns scheduled with ear, nose, and throat practices. My first exam that I'm doing today after this podcast is on the child of an ear, nose, and throat surgeon who's been doing tonsil and adenoid work for me, for the patients that we refer. So it's
that's a good point, is that, you raise a really good point, which is that the expanding your referral base to all of those specialists who are treating the kids for these different habits and anatomical challenges. Those are also opportunities to build relationships for referrals, and coupling that with, reaching out. This is what we do, but coupling that with reaching out to consumers, patients, parents directly is the other side of that coin, so that they're hearing it from their doctors, their specialists, that seeing an orthodontist at this time is a good idea. And they're doing their own research on their side, confirming that this is a good decision for their child. But we don't want to ever forget that the referral stream is still there, and they're important, and it's good to be building relationships with them, and, continuing to pay attention to that stream of referrals.
So Dan, I want to, in the short amount of time we have left, I'm looking at the clock, and I want to flip it back to some clinical stuff quickly towards the end. A couple of things that come to mind for me when I'm lecturing to both pedo and ortho residents, when evaluating the transverse, which is so critical, the less understood aspect of transverse in the maxilla, in my opinion, has to do with what's going on in the mandible. And if the mandible is not in a normal axial inclination, the curve of
Wilson.
Wilson, yep. Then
I remember it well.
Yeah, that oftentimes we end up under expanding. So we need to expand to a normal lower arch. So that's just one thing that I find. You don't need a cone beam in order to evaluate that. The other thing is that if I'm measuring the upper incisor and it's like 10 millimeters, 11 millimeters, or I have a bimaxillary protrusion, then I'm really questioning, am I going to try to treat this, non-extraction? That's just like a simple thing. You don't need a lot of records in order to do that. Don't. So I'm just curious, like, what advice would you give to our listeners? A lot of them are residents, younger practitioners that are just starting out, that are struggling with, should I do early treatment? I don't know. I haven't been taught a lot. How would you suggest that they get more knowledge, or advice that you might give them in terms of making those types of decisions?
Well, McNamara has made available to the public a PDF on Google search showing his, I believe, 2015 lecture on transitional dentition, where he brings up the 10 millimeter central incisor, where he brings up the 36 millimeter maxillary width, where he also shows devices, and he treats the mandible first to upright the lower buccal segment so that the curve of Wilson is not accentuated. I will agree that my failures in phase 1 early treatment have been because I have not paid enough attention to the mandible. And parents, I have never taken the approach of treating the mandible first, just because doing early treatment is enough of a shock to some parents. But when you tell them that they don't have, their patients are coming in because there's no room for the front teeth, and you say, okay, we're going to start by putting a Schwartz appliance on the lower, that's a little much for them to understand. So we start with expanding, and then when we get to a point where the lingual cusps are almost on the buccal cusp of the lower, we either put brackets on the lower, or we do a removable device. Or Invisalign, of course, really makes it easy. I mean, we've embraced Invisalign early treatment to a great extent. And the beauty is that it's treated in a pretty short time period. And because you can put the teeth where you want them, and you're not dealing with open coil springs and brackets, you can really position the front permanent teeth to look nice, and that's great.
Right.
But
I need to just interject and ask one personal follow-up question on that. Is what about compliance in a 7-year-old or 8-year-old with an aligner that needs to be worn, however, 23 hours a day?
I hear Kayla. I'm
just curious. I mean, I have the expert on the line here, so I'm going to ask.
Invisalign's own scientific research, and they measure everything, including how much time it takes each one of your assistants to scan a patient. I mean, they know everything. Mm-hmm. But their own proprietary research has shown, at least that's what my rep has told me, that the kids are better at compliance than adults. And I think if you asked my staff, they would agree, because the amount of time that we spend with adults trying to cover their tracks for, I was in Vegas or Nashville this weekend, I forgot my aligners, versus the kids that are really enthusiastic about making their smiles look great. I think we've had a great result with even
Invisalign as young as the littles.
Yes.
Okay.
Yes.
Good to know.
We've had good result with Invisalign.
Okay. Very good.
So.
Okay. Well, listen, thank you so much for taking the time to talk with us today, for answering all my personal questions about my daughter, Kayla.
It sounds like you'll be in good hands from what I understand.
Yes. Well, I mean, yes, definitely.
Yeah.
if our listeners are interested in learning more about early ortho, have questions for you, follow-ups, can they reach out to you? And if so, what's the best way?
Well, about 6 months ago, I created a Facebook group called the Pediatric Orthodontist. There's a Facebook page open to everyone called the Pediatric Orthodontist. And then there's an associated website, although it's kind of small right now, but there's a pediatricorthodontist.com website. And my intention is to start filling it up with all the case reports that are sent in from other orthodontists that follow the page and myself, so that it's a resource for, like you said, residents, orthodontists, patients. The website is available to anyone. The Facebook group is available only to members. And we're encouraging people on the Facebook group, the Pediatric Orthodontist, to upload photos, before and after cases, discuss the cases that I'm showing. I put one case up about every 2 weeks. I try to limit it to a 2-minute video so that people can get in, see what's going on, and move on with their life. Mm-hmm. And my intention is to make it a growing, living site that mm-hmm. continues to show the goods and the bads of early treatment.
That's great.
What I do at the end of the cases that I show is I critique myself. Here's a case where we got our maxillary width to 34 millimeters. Our ultimate goal is 36. I think I could have uprighted the lower molars more, things like that.
Yeah. Okay, great. So we're going to encourage our listeners to visit that Facebook page and answer. You can interface with you there. You'll answer questions, things like that. To visit the website, we know it's a work in progress, but they can learn more there. And that's one thing. So thank you again.
Yes.
Really appreciate your time. Looking forward to hearing more, and hope to have you on again in the future.
This is enjoyable. I love spreading the word.
You do it well. We appreciate it. You can subscribe or download other episodes of the Golden Age of Orthodontics podcast on Apple Podcasts, Spotify, SoundCloud, YouTube, if you want to see us, or wherever you get your podcasts. And if you enjoyed it, we would appreciate very much if you would tell a colleague, especially with this episode, if you know that they're interested in early intervention. For more information about people in practice and about how we can help you bring that younger set to the practice for their exam and, educate those adults, the parents, about early ortho, visit our website at pplpractice.com.
Dan, thanks a lot. We really appreciate
Leon
it.
And Amy.
Yep. And for our listeners out there, I'm interested in what you think. Shoot me an email at leon@pplpractice. Do you do early treatment? If not, why not? If you do, what resources do you have? We can open up a discussion and share some information. I think it can only help all of us. And if you're looking for the best marketing company in the world, shoot me an email there as well, and let's talk. And most importantly, remember, it's never been a better time to be an orthodontist. We are in the golden age. So please take advantage of it now. Till next time, see ya.
Thank you for tuning in to the Golden Age of Orthodontics. Subscribe now on Apple Podcasts, Spotify, or visit our website at thegoldenageoforthodontics.com for direct links to both the audio and video versions of this episode.